Welcome to the Explainer. Listen, if you're a busy medical trainee, you know you need a solid game plan for common conditions. So today, we're going to tackle mitral stenosis, and we're going to do it just like you would in the clinic, from that very first symptom all the way to the final management plan.
So here's the plan. We'll start with the basics. What is this condition and why does it happen? Then we'll talk about how your patient is actually going to show up. After that, we'll cover how you lock in the diagnosis. And finally, we'll get into the nitty-gritty of treatment.
All right, let's dive right in. To really get a handle on this, we've got to start with the fundamental mechanics. What's actually going wrong inside the heart? So at its core, mitral stenosis is basically a plumbing problem. You have the mitral valve, which is supposed to be this perfect one-way door between the left atrium and the left ventricle. Well, in mitral stenosis, that door gets stuck. It just can't open wide enough. And the number one culprit, far and away, is long-term damage from rheumatic heart disease, where old inflammation has literally fused the valve leaflets together and made them all stiff and calcified. Now here's something that should really jump out at you. When we're talking about rheumatic mitral stenosis, look at who it affects. We see a really striking 4-to-1 female-to-male ratio. That is a massive demographic clue you have to keep in your back pocket when you're building a differential diagnosis. Now, while rheumatic disease is definitely the main player on the world stage, it's not the only cause. You've got to remember there are other things that can do this, like really heavy calcification of the valve support ring, scar tissue from radiation to the chest, or even some pretty rare congenital problems like something called a parachute mitral valve. Okay, so we know what's happening to the valve, but how does that mechanical issue actually turn into a patient's story? What are they going to tell you when they walk into your clinic? You know, one of the most defining things about this disease is just how slow and sneaky it is. A person could have had rheumatic fever as a kid and then feel perfectly fine for decades. And that's a huge clinical point, because when symptoms finally do show up, they can be really subtle. Patients might just blow them off as getting older, not realizing that the valve has been getting tighter and tighter for years. The classic complaint, the one you'll hear most often, is shortness of breath when they try to do anything active. See, as that valve gets narrower, pressure starts to back up into the left atrium and then into the lungs. This gets way worse anytime the heart rate goes up, like during exercise or pregnancy, because that cuts down the time the heart has to fill, spiking that pressure even more. And that's what leads to the fatigue, the swelling, and eventually, the big complications like atrial fibrillation. And we have to be clear, the stakes here are incredibly high. If this is just left to run its course, the outcome is pretty grim. The majority of patients, something like 60%, will eventually die from progressive heart failure. The other major killer? Thromboembolism. We're talking about things like stroke, which is often a nasty consequence of having AFib in a big, stretched-out left atrium, where blood can just sit and form clots. Okay, so your patient is in front of you. They're telling you they get winded walking up the stairs. Maybe they feel their heart flutter sometimes. Mitral stenosis is on your mind. So how do you go from just a suspicion to nailing down the diagnosis? Before you even think about ordering a test, the most powerful tool you have is already around your neck. Seriously, a good, careful cardiac exam can tell you almost everything you need to know. So what are you listening for? Well, there's this classic triad of sounds. First, you'll hear a really loud, sharp S1. Sometimes people call it a tapping sound. Then, right after the second heart sound, you get this high-pitched opening snap as that stiff valve is forced open. And finally, you get that characteristic low-pitched diastolic rumble as blood struggles to get through that tiny opening. Now, while your stethoscope gives you all these fantastic clues, the gold standard, the test that confirms it, tells you how bad it is, and helps you plan what to do next, is the transthoracic echocardiogram, or TTE. It gives you a direct look at the valve, and it's incredibly accurate. So when you get that echo report back, what are the magic numbers that tell you this is severe? The big one is the mitral valve area, or MVA. If you see a number that's 1.5 square centimeters or less, that's your cutoff for severe. And just to put that in perspective, a normal healthy valve is somewhere between 4 and 6 square centimeters. So you can see why that tiny opening causes such a massive pressure backup. Okay, so you've done it. You confirmed your patient has severe mitral stenosis. The big question is, now what? Let's walk through the game plan for how we manage this. The decision to intervene really follows a very clear logical path. First question, always, is the patient symptomatic? If they have severe stenosis and it's causing them significant problems, it's time to do something. The next step is to look really closely at the valve itself on the echo. Is it still kind of flexible, or is it basically a rock? That's what's going to help you decide between a balloon procedure or open heart surgery.
For the right patient, and by that I mean someone whose valve is still pretty mobile and not just a solid chunk of calcium, this procedure, the percutaneous balloon microcommissurotomy, or PBMC, is a fantastic option. They basically thread a balloon up and use it to split the fused parts of the valve open. And in the right person, it has an incredible success rate.
But, and this is a big but, there are two absolute deal breakers for doing a PBMC. First, you absolutely cannot do this if there's a blood clot hanging out in the left atrium. You could easily knock it loose and cause a massive stroke. Second, you can't do it if the patient already has a leaky mitral valve, because the procedure would just make that leak even worse. This is why we often get a transesophageal echo right before, just to be sure.
Okay, this next part is a critical, high-yield pearl for your practice. A lot of these patients go into atrial fibrillation, right? So they need anticoagulation. And your first thought is probably a DOAC, because that's what we use for almost everything these days. But stop. In this very specific population, rheumatic mitral stenosis with AFib, warfarin is still the standard of care. Studies have actually shown that DOACs, like rivaroxaban, are inferior here and lead to worse outcomes. It's a huge point to remember. And finally, what do you do for the folks who just aren't good candidates for any procedure? Well, this is where medical therapy comes in. And remember, while meds don't fix the valve, they are absolutely essential for controlling symptoms. We use diuretics to get fluid off the lungs and agents to slow the heart rate down, which gives the ventricle more time to fill and can bring a lot of relief. So let's wrap this up with the key takeaways. Mitral stenosis, usually from rheumatic fever, way more common in women. Your exam is key. Listen for that loud S1, the opening snap, and the diastolic rumble. The echo is your gold standard for diagnosis. Treatment is a balloon procedure for flexible valves, surgery for the rest. And please, please remember, if they have AFib, the answer is warfarin, not a DOAC.
And I'll leave you with one final question to chew on. Rheumatic disease is a systemic problem, and it very rarely just hits one valve and leaves. So, what's the most common accomplice to mitral stenosis? Which other valve is most likely to be damaged right alongside it? Something to think about. Thanks for tuning into this Explainer.